Yes, so now we're shifting our gears to a focused presentation that highlights the power of innovation, collaboration, science in saving lives. In a world where cardiovascular care is evolving rapidly, staying ahead with evidence based innovation is the key to improving outcomes for millions of Indians. And it is my absolute pleasure to welcome a true leader in medical innovation and cardiovascular excellence, Dr. Rishi Jain, Country Medical Head, Novartis, India. Dr. Jain will share his perspective on how groundbreaking medical advances are transforming cardiovascular outcomes, shaping the future of heart health in India. We would like to welcome Dr. Rishi Jain on stage. Can we have a round of applause?
Welcome, sir. And all my young colleagues, it is your time to take out your notepads because this is going to be information and knowledge. Welcome, sir. Thank you.
Thank you and good morning, everyone. Thanks to the Voice of Health team for inviting me. It's a task to speak after Dr. Trehan and keep the momentum going. I'll try my best. So I'm not going to talk about medicines and products because this is more into the problem. So I'll touch more on the problem and how big is the problem and what together we need to do to solve this problem. These are few of my disclaimers. All the opinions are mine and it's not from the organization side. We were talking about cardiovascular, right? And we talk about cancers, we talk about multiple diseases. Cardiovascular diseases are the #1 cause of death globally. And we talk about cancers most of the time. I also work in oncology. I see lots of oncology drug. The focus and attention, what we get when we speak about oncology is much, much more than when we talk about cardiovascular. But if you see the facts, cardiovascular deaths are much, much higher than the deaths due to oncology diseases. And to make these numbers little simpler, these may not make sense. In 60 seconds, while I'm speaking to you, in 60 seconds, can someone throw a number how many people die of cardiovascular atherosclerotic disorders due to MI and stroke? In 60 seconds, how many people die globally? 5, 10, 20, any number? Every 2 seconds, we are losing a human being because of atherosclerotic disorder. So when I speak this, also people are dying. So every 60 seconds, around 34 people die with atherosclerosis worldwide due to MI or stroke. So is it not mind-boggling that the numbers are so huge? Every 60 seconds, we lose 34 people because of atherosclerotic cardiovascular diseases which end up into MI and stroke. As a country, we were talking about the opportunities what we have, but on the other side, if you see from a disease perspective, is it genes, is it our lifestyle? I don't know what it is, but we are not doing really great. Why we are not doing great is we get the disease earlier in the age. We saw people saying that Indians get almost 10 years earlier the myocardial infarction and stroke. So we get it early. The disease shows a poor outcome and exhibit a more severe form. So the mortality is higher. And if you look at the numbers, we touched about 54.5 million, which is roughly around 6 crore people have this disease. And 25% of all death, out of 1% dying anywhere in India is because of cardiovascular death. So the numbers are mind-boggling. But what worries me more is not the number. So the problem is there. But what worries me more is unawareness of the problem. And I'll talk to you about unawareness about the problem from US perspective, and then we can imagine how the situation will be in India. So in US, so LDLC, I'll talk about LDLC, which is, I see some students probably here, so which we commonly say as bad cholesterol, which I personally don't like to call it a bad cholesterol because we are trying to not hit the nail on the head. We need not use words like good cholesterol and bad cholesterol. There are so many types of cholesterol. Let's pin it directly to LDLC cholesterol, which is the most important culprit. And when in US they did a survey, they found people having LDLC more than 160, between the range of 160 to 190, 50% of the people were not aware that they had a high cholesterol. And when it was above 190 also, almost 25% of people were not aware that they had high LDLC, which is more than 190. And 190, let me tell you, is very high because in normal people, we expect it to be less than 100. So it was almost double of that, but people were not aware. These are people who did not had any myocardial infarction or stroke. If I talk about people who had stroke or myocardial infarction and have survived, 55% of those people were still not aware about what LDLC level they had. LDLC is one of the most important causative factor. It's a modifiable causative factor which leads to MI and stroke. And 55% of US people who had an MI and stroke were not aware that what their LDLC goal is, what is the LDLC they should be at. So problem is there, but the bigger problem I see is the awareness. We see there is a lack of awareness. And we did a recent survey. Not a survey, it was a patient advisory board. We spoke to 10 Indian patients who had myocardial infarctions. And none of them were aware about LDLC. They only knew good cholesterol, bad cholesterol. None of them knew about LDLC cholesterol. None of them knew what is the target LDLC they should be at. So the problem is wider. It's not only being prevalent atherosclerotic disorder, but also the awareness, which I think all of us together need to solve for. This is the ICMR India B study, which showed that out of the most important CV risk factors, lipids was one of the most critical modifiable CV risk factor in South Asian patients with myocardial infarction. While we have worked so hard in the past, the numbers have not changed. Either they have plateaued or they continuously increase. So we have not seen the trend what we would love to see. We will like to see the number of cardiovascular deaths going down, but unfortunately that has not happened, and we still see the cardiovascular death continues to increase, or in some countries this may have plateaued, but the way we want to see this trajectory, it's not happening that way. The trends demonstrate need for increased investment in prevention and treatment. And treatment is one part of it, right? But when you talk about public health, treatment cannot solve the problem. The problem has to be solved by prevention. We need to work in a direction that we are able to prevent these problems. And the prevention can only happen with awareness. If we are able to raise awareness about LDLC goal, and hypertension, diabetes are also big problem. But one good piece is people are aware. Most of the people know what high blood pressure is. Most of the people know what high blood sugar is. So they know diabetes, they know hypertension. But awareness about lipids, awareness about hypercholesterolemia is still very, very nascent, and we really need to work on improving that awareness. 80% of Indian ASCVD patients are unable to reach their target goal. And this is a bigger problem. We know the target goal, HCPs knows the target goal, we have medications available in the country who can help us reach there. But in a recent study which we did at more than 600 patients, we realized that 80% of the patients were not at the target goal. And this is not the right situation to be in. We are doing a larger study with 6,000 patients to revalidate the finding, but the numbers are in the same direction. 80% of the people are not reaching the LDLC target goal, and the awareness that they are not at goal is much, much lesser. The problem is medication adherence. So we do have medications which can help us reach the target goal. But what we have seen, people are not adherent to the therapies. They take therapies for some days, some months, and then leave the therapy. So adherence has come out as a very, very big problem. With more than 50% Indian patients show less to moderate adherence to lipid-lowering therapies. And another problem due to adherence comes is the variability. So we see LDLC level are not stable. They come and up. And this brings me to the next point is, while bringing LDLC down is important, it is very important. But another two things which we need to consider is when. The earlier we are able to address the problem, as early we are able to bring, plus sustaining it at that level, these are the two important things what is needed. While many of the people are able to reach LDLC goal, but they are not sustained, and they go again, the goals are increasing. So two important things to remember is how do we reach the goals early, and how are we able to sustain those LDLC goal, which is very important. The problem is not for one day. The problem is a lifelong problem. Like we have to manage our blood pressure from a long-term chronic perspective, we have to maintain our sugars from a long-term perspective. Same is for lipids. We need to really maintain as early as possible and sustain that reduction. And why it is important? Because there is enough data to suggest if we are able to reduce LDLC level, if we are able to reduce the blood cholesterol levels, the benefits are proven. The benefits are proven in terms of reduction in myocardial infarction, in terms of reduction of all-cause mortality, in terms of reduction of death. So we have all the benefits proven by multiple studies which show that important is to reduce the LDLC cholesterol because these benefits will remain. There is an urgent need to bridge implementation gaps in healthcare systems to improve population outcomes, because until unless we find solutions which are sustainable, which can be rolled out at a population level, it may not be possible to address this problem. Important is to find these barriers. What are the barriers? Why we are not able to address these problems? Innovate strategies. Find innovative solutions. And very recently, Novartis as an organization has brought up a very innovative solution to manage LDLC cholesterol. So this is an injectable therapy which is given once in 6 months, which addresses a lot of problem of adherence. So we saw adherence is a very big problem. So these patients are given just one injection in 6 months, and their LDLC are able to be managed for sustained reduction for almost 6 months. So we need to look at innovative solutions, implement those solutions, and sustain achieved improvement so that we are able to adhere to the goals what we have planned for. Just to conclude, ASCVD is a diffuse disease making comprehensive risk factor management essential. Elevated LDLC contributes to the development and progression of ASCVD. Recent guidelines recommend lowering the LDLC target to less than 55 mg per deciliter, reinforcing the principle that lower is better for LDLC cholesterol. Greatest CV risk reduction is seen in patients with the largest LDLC decline, while those without LDLC improvement remains at the highest risk. So it's proven that if we are able to address the problem, we can save a lot number of lives. So the last message what I want to leave with is, the lower the LDLC we are able to achieve, the sooner we are able to achieve, and longer sustained LDLC reduction what we are able to maintain, it is a key strategy to reduce ASCVD risk. Thanks for this opportunity.
Thank you so much, Dr. Jain. Sir, if you can join us here, and I'll invite Dr. Nishal to please step up on the stage to hand over a small token of our gratitude to you, sir.
Thank you so much, sir, for that amazing presentation. Can we have a round of applause?